the economy and to make sure that our citizens are either not dying or not getting poor so that they can contribute to the economy. Have I explained it to you simply? Asanteni sana. Now with those very many remarks, I want to welcome you. So as you ask questions, please try to think the way you make the presentation. Welcome.
My colleague PS, ladies and gentlemen, good morning. Good morning. Bwana Yesu asifiwe. Unajua health sector, hapo ndio maneno inakuanga. So lazima ujue kama watu wameamka sawa, kama if everybody has taken a meal, you're feeling better, because if we are unwell, we wouldn't be here today. I think, PS, you have actually summarized my speech. And I love it because we do this together. I will not have a lot of a hard time explaining. You've given it into perspective. So today, as the chair of the health sector, I stand before you. And I have a resolve, and I feel we have a vision that is rooted in realities of our beloved nation. Because we are at once a nation of remarkable progress and a nation with responsibilities that demand courage, compassion. It's a nation that is steadfast on unity. And our journey towards universal health coverage, healthcare, it is not a distant dream, as you have seen what we have been doing in rolling out our universal health coverage, because it is a lived obligation we shoulder together every day, in every county, in every home. Therefore, when we look at the rights and our commitments, Kenya's guarantees the right to the highest attainable standard of health for every person. And this is not a luxury, because it is in our constitution, and it is guided by other areas, the Vision 2030. It's guided by the medium-term plan for. It's also guided by the bottom-up economic transformation agenda. And we have made health a pillar of the national transformation. The universal health coverage, again, is not just a policy that we've picked on the roadside, because it is our moral commitment to ensure that no Kenyan is left behind. So our sector's mission is very clear, and it is basically to build a progressive, responsive, and very sustainable health system that accelerates the attainability of the highest standard. Ladies and gentlemen, what we do and what we achieve allows us to reflect on concrete progress that shows what is possible. One, the strengthening of access and continuity of care through the 228 out of the 315 primary healthcare networks that have already been established. And this is linking a primary healthcare network is actually the geographical mapping of facilities within a specific area. And that primary health care network is what links you to the facility near you, the level 2 up to level 4. When you register for SHA today, you realize that it gives you a number of facilities that are near you for your selection. So that comes from the primary health care network. We are required to have 315 primary care networks, and we are at 228 so far. Again, empowering of communities. We are talking about 107,831 community health promoters that have supported over 7.8 million to a shared responsibility that begins at the household level. The community health promoter ensures the safety, the standards, the accountability, a quality healthcare and patient safety. Sorry. When we talk about the CHP again, being at the lowest level um, of community health work, we have them moving from one household to another. We are lucky that the previous budget, we have a budget to pay them. However, we still have commodities that they have to buy. We have dewormers that they have to have. And when they go to a household, they need to take blood pressure. They need to check blood sugar of the household individuals. And 7.8 is not just a number, because every household, an average household in Kenya, has about 5 individuals. So that translates to more than 30 million people who the community health promoters have come across. I want to talk about the safety standards and accountability, where we have the Quality Healthcare and Patient Safety Bill, which now anchors care across levels of facilities. And equally, the issue of AMR surveillance that has expanded from 17 to 28 laboratories, enhancing our ability to detect and respond to antimicrobial resistance. It's the nature of Kenyans, or do I say human being? When they feel that they are unwell, they run to a chemist, they buy antibiotics with no prescription, but at some point, the medication will not respond to your body. And that is why we are very keen about antimicrobial resistance. So when these are not just statistics that we are giving, they are the faces of mothers who receive timely vaccines, communities protected from preventable illnesses, and health professionals who are supported to deliver. Our most important asset, when we talk about immunization, that remains a cornerstone. You have heard even His Excellency yesterday talking about maternal deaths, that we are not going to allow mothers to die on the delivery bed. And even after delivery, we do not want our children to die for lack of immunization. So Penta 3 coverage consists above 83% a shield for our children. Vitamin A supplementation exceeds 83% coverage, and HIV, on HIV response, we have prevalence decline from 3.7% to 3.03%. ART coverage has reached 87% of eligible clients, and MTCT rates fell decisively under 8% by 2022. On malaria control, we have intensified with 16.5 million ACT doses and 4.7 million nets that have been distributed successfully. So these achievements are a testament to the dedication of our healthcare workers and the trust of communities and the steadfast support. However, we cannot fail to mention the challenges that we embrace as we continue in this sector. And we recognize that despite the successes that we've had in the sector, we also have gaps that remain glaring. Our progress in digital health, 18% of facilities with end-to-end electronic data system, shows how far we have come and how far we must go. So our shared medicine availability at 62%, we would want to take it to a higher percentage. So we stand at 62% as a call to action and access to medicine people need to have. That should never be something like a lottery. Again, we have blood supply that remains below the WHO recommended minimum. These are just but a few areas that we must mention. If you look at 18% of the digital health connectivity, why are we not even at 50? Why are we not at 60? Why are we not at 80? Maybe because of the finance gap that we have. And that is why we are doing this presentation today to the public. And we can try and reason together and see if this is an area that we must really look into. Interrelatability of data is very key. Before, you would go to a facility with a quota exercise book. But today, because of digitalization, we are able to move from one level of facility to another, and you will not need to repeat the stories that you told talked at first level. The issue of hakuna dawa, it must come to an end. We have done reforms at KEMSA, and all we need is to have our refill and the confidence of Kenyans that there are drugs even at the facility level. So at 62% again, we can move it to 100% with clear indication that these drugs are going to right to the facilities. And if I remember the quote that His Excellency equally used yesterday, and he talked about drugs coming from KEMSA and going right to the facility, because that is where we need that service. The blood supply, which remains below the WHO recommended minimum, and reminding us of the humbling reminders that health is a fragile, life-saving good. We also draw our strength equally away from the challenges that we are a nation that has shown the capacity to surge forward when we unite in purpose. So the strategic priorities for the year 2026-2027, as we chart the medium-term expenditure. Sorry, I think you'll have to follow the screen. I am explaining, so I hope we are moving in the right direction. As we chart the medium-term expenditure framework, we anchor our work in 5 interlocking commitments. And the first commitment is people-centered prevention and health promotion. You see, we do not have to get to the point that we have to take somebody to a health facility for treatment if we can prevent it at home. And we have doctors in the room today, including my colleague, Dr. Oluga, and they will tell you that almost 10 ailments are preventable, starting from malaria, cholera, and many bilharzia. They are preventable. So why are we not protecting ourselves at home? Why are we not having that urge to preach and educate people, educate the masses? Maybe we do not have that human resource to go from house to house giving that service. Therefore, at this juncture, we need to agree as Kenyans that a people-centered prevention and health promotion is very, very critical. So expansion of preventive and promotive services to reduce disease burden and protect households before illnesses strike is very key. We already have the 107,831 community health promoters. How are we leveraging on this number to ensure that the services that they are delivering are key? Again, strengthening health literacy and community engagement so that individuals are empowered to make informed and healthy decisions. When we talk about non-communicable diseases, lifestyle diseases, it is simply a matter of calling people in such a room and helping them understand why they need to eat healthy. Financial protection and access, building on the Social Health Insurance Fund, the Primary Health Care Fund, the ECCIF to ensure financial risk protection and broaden coverage for essential services so no Kenyan is pushed into poverty by illness, and equally scaling up digital health to improve efficiency and reduce the out of pocket. Ladies and gentlemen, we are rolling out a robust insurance system for every Kenyan. Therefore, funding of the primary health care fund is non-negotiable. Again, the emergency and chronic illness fund is equally non-negotiable, and it is done through the exchequer. It would be paramount that while you are working in Nairobi, nobody calls you from your village to tell you to give you money for registration at a facility. It should be free. It is free. And therefore, the government has a commitment to keep putting in money for primary health care fund. Again, the emergency and chronic illness. We do not want anybody who gets an accident. You can get an accident even in your house, or you walk out of your house and you're knocked by a vehicle, you fell in your bathroom, and when you're rushed to a health facility, you are unconscious, but they want your relatives to be there. How will you talk about your relatives and you are not even with them? It is unacceptable. Therefore, we must ensure that there is financial risk protection for every Kenyan, and that is why we have the ECCIF. I want to talk briefly about the quality standards and regulation institutionalize and continue updating of standards of care, professional regulation, and safety, ensuring every patient experiences care that is effective and is respectful. Many a times is when, even if you go and Google health facilities in Kenya on Facebook or any social media, you'll find a clip playing here and there of a patient saying how they have received services that are not at par or to their expectation. We are not supposed to be receiving this information online. We must have a way to cover the patient, that every other time if you go to a facility and you're not happy, you have a channel, you have somewhere you can channel your frustrations. And we in the Ministry of Health are able to respond to your call at any given time. And that is why, ladies and gentlemen, we have introduced the Quality of Healthcare and Patient Safety Bill, which is now in Parliament. We want to have an agency that will oversee the quack facilities that do not have right infrastructure, that they do not have the right human resource, facilities that may not be having the right the right commodities. Maybe there's fake medicine that has been sneaked in. We want the patient to tell us that this is happening. So through the Quality of Care Bill, which we are clear and we want to implement, it will be a good channel for the Ministry of Health and Kenyans to have a communication channel. And again, expansion of capacity in training institutions, supporting both pre-service and in-service learning for healthcare workers. Every year we have postgraduate training. And we have made it very clear to the counties, the role of the national government is training and policy. So in training, we want the counties to give us, to do training to our healthcare workers on need basis. We want to know the gaps, and then we can fill in those gaps by training for them the right healthcare workforce. If you need a gyna, then send one of your medical officer to come for further training, for postgraduate training. If you need a pediatrician, if you need a surgeon, then we will be able to clearly achieve this with the right financing and the more we train and the more we have skilled workforce at the county level or at the bottom of the pyramid, the more we reduce the deaths that we experience today. Again, investment in healthcare workforce development with targeted training, targeted mentorship, and retention strategies. We also would not want that we train and we train for other people. We want to train for our nation. So retention, how do you retain a good healthcare worker? It is by good remuneration. So we want to pay our healthcare workers well. It is by ensuring that they have growth in their service. And this can only come through planning. We plan better. We are planning for the next financial year. Therefore, how do we do it? We have to probably increase the financial resource so that we are able to deal with the same. Our premier mid-level training college, again, the Kenya Medical Training College, training more than 18, training almost all the cadres, but equally having specialized training. KU, Kenyatta University Training College, again, they have introduced specialized care in their training for nurses. So again, we need to support and have research and innovation to drive evidence-based practice and homegrown solutions to Kenya's health challenges. Ladies and gentlemen, let me speak about the high impact services and specialization. We are talking about accelerating access to high demand, high impact services like cardiovascular care, kidney and oncology services, maternal and child health and preventable oncology, and cancer detection. Leveraging on Kenya's landmark milestone, the regional leadership in specialized care, including advanced surgical and transplant capabilities to attract patients regionally while strengthening national capacity. I know of our new kidney institute that is taking care of this. And we are very, very keen to have it operationalized to ensure that it is attracting even regional attention. Therefore, that is one of our key priorities. These priorities, ladies and gentlemen, map to tangible outcomes for when we talk about more women delivering safely, fewer children missing vaccines, earlier detection of cancer, and healthier communities that can participate fully in our nation's growth. Realistically, we need to increase essential medicine availability to at least 75% across public facilities within the next 3 years with robust pharmacovigilance. Again, we need to achieve at least 25 million individuals registered. Sorry, we are already past 25 million. So this I must have picked. We need at least 35 or 40 million individuals registered under social health protection schemes by 2028-29. We equally need to expand end-to-end digital health coverage to 50% of public facilities, from a mere 18% of digital coverage in our public facilities. Let's shoot it to 50%. At least you will be sure that in any facility you go, you'll find your name there, and enabling timely data-driven decisions. Again, sustain and accelerate reduction in maternal and child mortality through targeted RAMCA interventions and increased access to skilled birth attention. I have a call to action. Health is a shared enterprise. And I'm calling it enterprise because we have suppliers, we have our NGOs, we have healthcare workers, we have health managers, we have county governments. It's all in one basket. We have development partners, and I can see some in this room. We have the academia, we have the civil society, and most importantly, the people of Kenya. So all of you are an integral part to this mission. We are not leaving anybody behind. So to our development partners, your technical and financial support accelerates reforms, research, and capacity building that no single sector can achieve alone. To the county governments, who are the front line of service delivery, and their leadership and governance and accountability will ensure what works in policy becomes real in clinics and communities. To the healthcare workers, your dedication and ethics and daily service are the heartbeat of our health system. We commit to supporting you with training, fair remuneration, safe working environment, and opportunities for career growth. And to our communities and citizens, take charge of your health, demand quality services, and participate in accountability mechanisms that strengthen our health system. It is you who can tell me where the pain points are. And a vision of what Kenya will look like when we succeed, a Kenya where a mother can access Ramka services and deliver in safe, well-equipped facilities. We already have, my colleague is working on a robust program of equipping facilities across the country. And a nation where immunization coverage remains consistently above target, protecting children and families from preventable diseases, and a health system where financial protection is real and families seek care promptly without fear of catastrophic costs, an environment where diseases of old age and new threats are addressed through prevention, early detection, and effective treatment, and a country that continues to lead in medical innovation and regional health leadership, delivering life-saving care across borders and within. Ladies and gentlemen, this matters. I would want to go and take my seat so that I take back the mic to the chair of the session, who is going to lead in the next session. Thank you very much, and God bless you.
Thank you so much, Chair of Health Sector, who is also our PS for Public Health and Professional Standards. And I would like to inform members of the public and all our partners and stakeholders that in this room we have also National Treasury, and we also have State Department Economic Planning, and we also have within our Ministry of Health combined, we have very senior officers, including CEOs of our parastatals. In fact, may I just request them to stand so that I can introduce them, so that we know who you can also target your questions to as I go to this session. So, yeah, we have here Douglas Bosire. Douglas Bosire is the acting CEO for the National Syndemics and Disease Control Council. We have Dr. Otuori Dennis from the back there, who is from the National Spinal Injury Hospital. Yeah, and we have you are not Zainab Gura. Yeah, you are representing Kenyatta University Teaching and Referral Hospital. And we have the man who needs to, okay, I see many people. Yeah, we have all our institutions representing Kenya Biovacs. It looks like the CEOs, the ones I'm familiar with, their names are not with me. Oh, Dr. Kubias and oh, Kenya. Thank you. You can sit down. This one's in front. You can still stand. Thank you. We have the man of the medicines. Yeah, the man of medicines. You know, there used to be a program called the Man in Memphis. So you're the man of medicines, Dr. Ejesa Wako, who is the CEO of KEMSA. So kama hakuna dawa kwa hospitali, uliza yeye leo. Kwa nini hakuna dawa kwa hospitali? Then MTRH, we have Dr. Kirwa, who is the CEO. Philip. Oh, yes, we have Shah, the Director of Finance, Jonathan. Then we have representative from Kenyatta National Hospital, who is the Deputy CEO there and Head of Strategy, Makanga. We have Wako again, who is a regulator, Clinical Officers Council. We have Anne, who is from the Nursing Council. And we have Occupational Therapy Council. Thank you so much. And Nendo. And we also have directors here. So swali yako yote hata kama unataka kuuliza swali ya procurement, kila kitu, finance. So we'll go to that session. We have exactly 1 hour. We will give the opportunity. We'll give opportunity to members of the public more. And I would want your hands to be down just a bit. Just a bit. But okay. So yeah. So we'll take 10 questions. 10 questions. Once we take 10 questions, we will discuss, and then we'll take another round of 10 questions. But I said 1 minute or less each, and we will stop you. You know, Kenyans, we have to be stopped sometimes. So we will stop you. But before I do that, there is an institution that does research, and that's the Kenya Institute of Public Policy Research. They sometimes do research on either the impact of what we have done to see whether we are doing the things that we are saying we are doing, and whether those things that we are doing are having impact or not, or they do research to tell us this is the direction you should go. So I want to invite them, but I'll give them, this is the public. This one is not the university. So we know that you are the Public Institute for Research. So as we say, it is plan. Medium-term plan is an extract of Vision 2030. So when you see Vision 2030, you extract it in supposed to be moving to what we call consolidation and sustainability. We are not at the point of establishment. That one we did already. The laws were passed in Parliament. We established SHA, we launched it. We established DHA. We established, the President inaugurated the KHRAC. All our institutions are stable. Now we are supposed to be going through consolidation and sustaining. So Kipre, I don't know whether I have, Mr. Odhiambo, Kipra. I don't know whether I have spoiled it for you, but that's how I would want you to do it. Thank you. Yeah.
So allow me to ride on the already existing protocol. Today I'm in the midst of doctors who are treating people. Me, I'm just a data scientist who is a doctor of philosophy. So I can. No, I'm 6'2", so allow me to. So as I was saying, today I'm in the midst of the real doctors, and Piers here is a doctor of medicine. Me, I'm just a doctor of philosophy, okay? And more of a data scientist. And at KIPRA, which is the Kenya Institute of Public Policy and Research Analysis, is a confusion between KIPRA and KIPRE, okay? Yes, yes, so, yes, those ones. So, I won't take much. Of course, I'll give a report. But our work, as the PS has tried, our work is to advise the government on issues to do with policy. So before and after you implement it. And as a data scientist, I'm not treating, I'm more interested in numbers. So that's why my presentation was fast, and I think the PS Mudoni has talked about the vision, a policy. What do you want to achieve? So when I look at the budget, I look at it with that mind. Are the numbers speaking to where we want to go? We're talking about MPT4, okay? Now, there's a lot, but because I've given 3 minutes, I want to even go to my slides. That one, I'll leave it. I want to talk about something. I spent my time, I was given a document which is almost 400 pages written of numbers. And then I chose, what do Kenyans talk about? I opened something called SHA. And I know questions are going to come there. Now, as an agency, we are interested in numbers, all right? And for us to talk about, you remember we talked about the article. If you look at that, there is article. Maybe go to the article. Just go to the next slide. Yes. The article 43A talks about issues to do with we want to have healthcare which is accessible to everybody and at the cheapest cost. Now, we will stop about that. Under SHA, I think PS, you're able to explain it where SHA is the authority, under it there are 3 funds. Most people know about SHIP, and they make a lot of SHIF, okay? But there are others which you talked about very well, what we call the Primary Health Care Fund, and of course the ECCCIF Fund, okay? Now, these 2 funds, people don't talk about them. So I went to the report and checked. Because this is where the rubber meets the bullet. When I talk about the Primary Healthcare Fund. And if you go to my slides, I think the government has believed that each year they spend around 1,900 per person, okay? 1,900 per person. That is what is should be allocated by the. So when I went to the report, I did not see, if you could go to my slides, maybe to the last one, just for the purposes of the public. Forget about now, just before there. Yes, just before there. Before there. Yeah. Just before. Yes. Now this is where, because if the government allocates about 900 and also 1,000, in addition to 1,000 for these quality optical services under the primary. So the primary health requires about around 73 billion. Now, PS, my training, I'm an actuary, and we do these things for consultancy for the private sector. Yes, what they're trying to do, what the government is trying to do is to try to replicate what the private sector has been doing. And I don't know why it has been a challenge, because we have data from the KNBS, which is an agency that has kept all the policies what we make, we get data from KNBS, which is something we could do. I was asking myself, if you had assumed around 30 million people, okay, 30 million people, and each of them need around 1,900 per annually. If you multiply that, how much money will that give you? I did my numbers. You could do your numbers and see what is being allocated there. Will it really get closer to what you need? Actually, my numbers came to around 58 billion, which is closer to what probably by 2027 we'll be having around 56 billion. Primary healthcare is not a big problem. The biggest problem is now the emergency. Go to the next slide. Now, what we call the Emergency Chronic and Illness Fund. When I look at the document, it was written, I think that it was written in almost 2 paragraphs. And this is a critical area that has to be addressed. Because For us to get to, I think the government, you are saying that they will, I think, put around 129 billion. That is what is required. But see what they are allocating, 15 billion. So I did my numbers as an actuary, and this was hypothetical. Probably, PS, we can have a conversation on how we can able to have numbers. And the reason why we're having a problem to go and convince the budget appropriation chair, okay, or the parliamentarians, is because we don't have numbers. Ask Kipra, when we go to numbers, they listen. And if you look at the document, it's not really written. So I did that, for example, if you assume me and you who are paying through SHIP and we are covered with other private, okay, let's say around 30 million Kenyans who don't have paycheck and they are dependents, okay? If you do that and you multiply by what you are allocating here, is around 150,000 per beneficiary. So ask myself, if you assume, because for us to get that number, we have to know a little bit of probability as a mathematician. What is the percentage of in-house and chronic illness? I assumed, with a little bit as an actuary, I assumed this data, we can get it from the KNBS. I assumed one person for every 1,000. If you use that, if you do the numbers, that will give you to around 45 billion shillings. 45 billion. You add another person for every, it goes to 90 billion and it keeps on growing. So by the time you get to 125 billion, which is required, we are only assuming that we are only covering 3 out of 1,000 people. You can now see how we need something about health financing. Otherwise, the reason why Kenyans are really complaining about this is because of the finance. And these numbers, when we give you a department, we can able to enable you. We go make a presentation with numbers, real numbers, and allow the people who allocate the money to see. Otherwise, we continue to use SHIF as the only fund to treat these two other. And me and you come from places where we used to cook with 3 stones. Remember those when we were young? Are we trying to balance SHIF to balance these other two? Remember there is this one and the other one. So PS, I think we will have a conversation about this report. And as an actuary, we can see how we can able to do this and have the numbers to allow you to convince the parliamentarians to allocate more money. I forgot about something, about the HPD policy, which you have to fast track. HPT, you talked about it, yes. Because that will open up opportunities for entrepreneurs. Okay? And that will make the cost of health financing go down. So it's something which I was privileged. I was nominated by Kipra to go and help developing. I don't know where it's reached, but maybe I can talk to the director, Dr. Eunice Jeru, who was responsible for that, or the directorate. Yes. So allow me to stop there because of time, but anything about policy, I can able to take maybe 1 or 2 questions.
Thank you so much, Kipra. And yes, we are not confusing you with Kipre. Kipre, we know, does a lot of work for primates and research and snakes, you know, and they are located somewhere in a bush, but you have air-conditioned offices in nice places so that the numbers can make sense. So thank you so much, Kipra. I just have 2 comments about what you've said. One is that we appreciate that analysis of data, and we think that our national treasury, especially economic planning, you know, we also have a problem. If we could get all of these numbers that you've said, we want it. But there are 2 things. One is there's the Constitution, Article 43, that talks about the rights. In fact, the whole of Chapter 4 of the Constitution talks about rights. Now, Article 43 talks about social issues, so health is among them. And then there is the interpretation of the Supreme Court. Supreme Court. People went to the Supreme Court to